Fork tip needle biopsy versus fine needle aspiration in endoscopic ultrasound-guided sampling of solid pancreatic masses, a randomized crossover study. Introduction. Tissue acquisition by means of endoscopic ultrasound, EUS-guided fine needle aspiration, FNA, is the standard of care for diagnosing pancreatic malignancy. Systematic reviews and meta-analyses have reported pooled sensitivity of 86.8% and 85% respectively. However, reported sensitivity varies, and some studies that have used strict cytological criteria and accounted for inadequate samples have documented less impressive diagnostic performance. In an international survey, only one-third of endosonographers reported a sensitivity for the diagnosis of solid mass lesions of greater than 80%. Needle size, aspiration technique, suction or no suction, slow stylet pull, and the use of rapid on-site evaluation, ROSE, have all been investigated as means of improving diagnostic performance without consistent benefit. EUS-guided fine needle biopsy, FNB, with acquisition of tissue cores for histological assessment offers the theoretical benefit of preserved tissue architecture, improved sample adequacy, and therefore better diagnostic performance. However, the majority of studies with the first-generation reverse bevel needle have found no diagnostic benefit. Recently, a new core biopsy needle with a novel fork tip has been introduced. Initial case series have suggested improved diagnostic performance compared with FNA and first-generation core biopsy needles. Prospective randomized studies to investigate this new fork tip needle versus FNA needles are lacking. Therefore, the aim of this study was to address this question in a randomized crossover study. Background. A novel fork-tip FNB needle has recently been introduced for EUS-guided sampling. The aim of this study was to compare the performance of fork-tip FNB histology and standard FNA cytology in the diagnosis of solid pancreatic masses. Methods. A randomized crossover study was performed in patients referred for EUS-guided sampling. 3 passes were taken with each needle in a randomized order. Only samples reported as diagnostic of malignancy were considered positive. The primary endpoint was the sensitivity of diagnosis of malignancy. Secondary endpoints included the amount of sample obtained, ease of diagnosis, duration of tissue sampling, pathologist viewing time, and cost. Results. 108 patients were recruited. Median age was 69 years, range 30 to 87, and 57 were male. 85.2% had a final diagnosis of malignancy. There were statistically significant differences in sensitivity, 82%, 95% confidence interval, CI, 72% to 89%, versus 71%, 95% CI, 60% to 80%, accuracy, 84%, 95% CI 76% to 91% versus 75%, 95% CI 66% to 83%, proportion graded as a straightforward diagnosis 69%, 95% CI 60% to 78% versus 51%, 95% CI 41% to 61%, and median pathology viewing time 188 versus 332 seconds. P less than 0.001 between FNB and FNA needles, respectively. There was no significant difference in cost between an FNB or FNA strategy. Conclusion. The diagnostic performance of the fork-tip FNB needle was significantly better than that of FNA. It was associated with ease of diagnosis, shorter pathological viewing times, and was cost neutral.